I'd like to welcome everybody to a recorded webinar on HCAPS. This is a really important topic, and we're happy to bring it to you today. My name is Bud Langham. I am an industry veteran in home health and hospice for about 20 years. I'm a physical therapist by background. I'm based out of Dallas, Texas. And today, I largely do advisory work for companies in the post-acute space, including companies like CareBestie. I would like to welcome a guest to our webinar today. Lindsey, I'd love for you to introduce yourself.
Yeah, absolutely. So my name is Lindsey Doak, and I am the Vice President of Data and Research for a company called Health Pivots, which provides home health and hospice organizations with any type of data they need. And I have a long history in home health. I've been working in home health for about, I think I counted, but it's like 20 years.
Yep.
20 years. I think probably you're up there with me. We're long-term home health and hospice people. Obviously, I've seen a huge transition in terms of what's been going on in home health over those last 20 years in a variety of different roles, education and data and business intelligence and research, but also have been spent a lot of time working in the HHCAPS and hospice CAPS environment, once helping manage a CAPS division and then going into the CAPS consulting and research. So I'm really excited here today to talk about our CAPS and what's happening with CAPS and why it's important and these changes that are about to happen in April.
Yes, well, you're certainly one of the most qualified people I know to talk about this topic, and so I'm really thrilled to have you with me today. So let's dive in.
Yep.
What is happening with CAPS in the home health space?
Yeah, absolutely. Well, I'll share some slides here just to give you a sense of what's going on. Here we go. All right. So what's interesting about CAPS is that you probably know this all started in 2009. I know we are doing patient satisfaction surveys way before 2009, but in 2009 is when they first created this HHCAPS. So you had to participate in a standardized survey that is the same for every patient across the board, right? And you can't have any sort of differentiators for your organization, and it's required. But that was in 2009. And then, we've changed so much in home health. As we said earlier, home health is a much different industry from 2009 than today. And what we came up with was the survey that existed wasn't actually measuring the true patient experience of care. So CMS went back to the drawing board for the first time since we've seen the CAPS survey come out.
Yeah.
And you and I were talking, the survey was too long. So they also looked at that to make sure that we could see if we could simplify it a bit. And then there's just this movement towards this patient-centered care, which we saw with the updated COPs in home health. We have a big movement for patient-centered care. And one of the biggest changes that CMS wanted to do is make sure that these elements of patient-centered care were incorporated into the CAPS survey. So I would say in the CAPS world, we consider these April changes huge changes because there have been no changes to date, right? Like we've never seen any movement in CAPS. And now in April 1st, we're going to have a significant amount of questions that will be simplified and updated and new questions added. So a big thing for home health. And what I truly hope comes out of this is that we do end up with a survey that truly does measure the patient experience.
Yeah, exactly. Boy, we need that. Times have certainly changed. And so what should agencies be thinking about in terms of CAPS?
Yeah, absolutely. Well, years ago, CAPS was required, but what had happened was that, there was no regulations around how CAPS impacted an organization. We didn't have CAPS star rating. We didn't have payment performance adjustments based on CAPS. Well, all of that has changed. So with the updates, we also see the bigger impact on the organization. What we're seeing is that we're going to see update to what an organization is rated with their star rating. So we currently have star ratings. They're great. You have the star ratings, but not a lot of people have that star rating. Right. We currently have star ratings, but they're going to change. So as of October of 2026 is the last time we're going to see any update in terms of CAHPS for those star ratings or any of the measures. In January, we will see an update to the overall rating of care and the willingness to recommend, but we won't see any other updates until October of 2027 for that. And those publicly reported outcomes are going to change with the updated survey. So this is a fresh start for a lot of organizations who've been working on their CAHPS and haven't seen much movement. For those of you then that are doing great, what I say is, you just continue to do great work, and in October 2027, you'll have those great outcomes as well. And then on the value-based purchasing side, which you saw this year, you've probably already been a part of this, is that we cut out a lot of what will be considered CAHPS values for value-based purchasing. So we went from 5 measures that were measured to 2. There was a significant reason for this. The reason was that there were so many large cohort organizations that actually don't have enough CAHPS data to even show up. And so they were being measured, even though they were in a large cohort, simply off of their OASIS and their claims. And so I think we adjusted the HHVBP slightly to accommodate this. The important thing to note about this change is that you think, okay, well, we only have 2 and they're 20%. So we have the rating of a 9 or a 10, and we have the willingness to recommend, and they're each 10%. Even though the total scoring has gone from 33% to a 20% for HHCAPS, you have to keep in mind now those 2 questions are worth 1.5 times their value from prior years, because you went from 5 questions to 33% to 2 questions to 20%. Really, really important to focus on those 2 questions. And what we've seen in the past is that if you can make even a 1% improvement to either that 9 or a 10 or the willingness to recommend with VBP, you actually get 3 to 4 times the number of TPS points than many of the OASIS measures, because that range is just so tricky for CAHPS. So that effort to try to help improve CAHPS and performance is definitely worth it when it comes to your value-based purchasing scores.
Yeah, so it's definitely more concentrated. And so agencies that are not taking that into account and focusing on those questions do so at their own peril, right?
Yeah, absolutely. And I know we all sit here and say, I've tried for so many years to make improvements to those, and they're hard, and that's true. They're hard, but you have to keep in mind you're not looking at with OASIS, you would be looking at like 5 or 6% improvement in your score, right? With CAHPS, 1% is going to help you significantly with all of those CAHPS-based measures.
That's a great point. Are there other reasons why these surveys are so important and something that agencies really should be focused on going forward?
Yeah, so I don't know if you heard about this, but the Consumer Report just released a new report ranking the top home health organizations across the country. Now, I looked at it, and I don't love their ranking. I will say that on screen, because what they did is, again, just like VBP, they made it so that those organizations that don't have enough CAHPS scores don't get penalized if they have bad CAHPS performance. And so, there's some work to be done there, but what we're seeing is this overall trend for organizations to have a need to improve their CAHPS scores, because the consumers now have access to look up and rate their own care. We're not living in the times of you would go to a hospital and they would say you should use X home health agency, and then you just did it because the hospital told you to do it. We're living in a time where consumers have access to their data. So patients, caregivers, when it comes time to finding a home health organization, they've always been able to go on Care Compare. Now they can go on this new, I'll start over. They've always been able to go on Care Compare. Now they can go on to this new Consumer Report. You're going to see more of that. And so as your outcomes are out there in the public, just know that that's how people are going to start choosing their home health services.
Yeah, I think the rise of consumerism is a good thing for the healthcare industry. The more publicly available data, the more information that's out there, the better. And our consumers are definitely becoming more educated on the types of services and the quality of services, the programs, what all these agencies can offer. So Lindsey, you've shared a little bit of the history with us. You've shared a little bit about what's happening, but let's go a little deeper into the details of what's happening April 1st and beyond.
Yeah, absolutely. So you can see here, this is a summary of what has changed with the new survey. And as I said in the beginning, if you take a look, this is a lot. This is a lot for CAPS. We haven't really seen anything like this in any of our past experience with CAPS. So the overall goal was to make this an easier survey to complete, more centered on the patient's experience, and then obviously shorten it a bit. So I think when they did it, they said they tested it out, and it's gone from an average of 12 minutes to 9 minutes to complete. Still, long 9 minutes. I'm not going to discredit the 9 minutes as a commitment still, but much better than that 12 minutes, right?
Yeah.
So we saw a lot of consolidated questions as well as remove questions. With the medications questions, you can see that was probably the biggest change. So we went from 6 questions to 2 questions. I think that the last survey talked about medications ad nauseum. How much went in? It was too much. So I'm happy that CMS recognized that was a lot. I've also never seen somebody rate somebody really well on a CAP survey, give them a 9 or a 10, say they're willing to recommend, and then write in the comments, I just loved how well they helped me take care of my medicines, right? So
exactly.
They probably recognized that and then condensed it. So some significant consolidation there. They reduced the race and ethnicity question to just the ethnicity question, which isn't significant, but again, it eliminates one question. The types of staff questions. So before you had a lot of questions around, what kind of people were a part of your home health interdisciplinary team. They've cut all of that. So they just call it your care team now, and they don't go into details about, how was your nurse? How was your physical therapist? How was your personal care? Because truly, when you see the patients, even though they probably are aware of these different people coming in their home, I don't think they're paying attention specific to discipline when they're ranking the quality of care they're receiving. So that just made sense to cut.
And I like that because it's a good reminder for clinicians in the field taking care of patients that we're all part of a team. Exactly. And we all have an impact on the score for this patient's experience and their healthcare journey. We've all got a responsibility to deliver excellent care. So I really like that change.
Yeah, 100%. This shouldn't be about, what did you think of your nurse? What did you think about your therapist? What did you think about your aide? It should be, what did you think about your care team? And together to deliver the right care for you.
Right, exactly. And so how do the consolidations and some of these removed questions, how should agencies think about these as they move forward past April 1st?
Yeah, so one of the biggest changes that has happened to the CAP survey is the care of patients questions. There's a publicly reported questions that have been broken down, but they're similar to what you've seen with CAPS in the past. I found that this was the best improvement to the CAPS survey. So you can see here a summary of the care of patients questions. 3 of the questions changed slightly. 1 question got eliminated, but they added 2 questions. And these 2 questions, I'm going to bet you today, Bud, we could put a wager on $100 or whatever you choose, that these 2.
I'm writing that down.
Okay, all right. And we're being recorded, so we'll have a record of this later. I predict that these 2 questions are going to be the highest predictors of your rating of a 9 or a 10 or your willingness to recommend in the future.
So you think this is where agencies really need to double down and focus?
I really do. I mean, there's other questions that are tied into that, with past research, what we've seen is that, was the clinician prepared before they came into your home was an important indicator of a willingness to recommend. Did they care about you? Was a willingness to recommend? And then did they listen to you was a direct correlation to willingness to recommend and that rating of 9 or a 10. So, you can see there's nothing about how well they took care of your wounds and how well they did take care of your medicines, right?
Right.
But the new care of patient questions are even stronger than those questions. And they ask about things like you see here. Did they care about you as a person? And
Right.
it is the center of patient-centered care, right? And I can't believe that anyone would get care from a team that they felt cared about them as a person and then leave unhappy with that home health organization. There's not going to be a disconnect there.
Yeah. I like the focus that this question puts on whole person care. So not just being transactional, running into a home, changing a bandage and running out, but actually asking those questions. How are you feeling today? Is there anything else I can do for you? Taking care of that patient as a whole person. I really like that.
Yeah, and it's what, you don't have to be in home health to see this. If you go to the doctor yourself, do you like a doctor that comes in, looks at you quickly, and then leaves? Or do you like a doctor that understands before they come in the room, perhaps even asks you about your family, you can see that they've actually gotten to know you and care about you? It's
Yes.
almost always that latter doctor, right? So it's the same. Everyone wants to feel like the people who they're putting their hands, to take care of them and help them get better also just care about them as a person.
Yeah.
The other question that is really, really important here is this, again, it goes back to this patient-centeredness, is the question of, did this agency help you take care of your health? A lot to unload with this question, right? Because
Yes.
you've seen it working in home health organizations. This can be a struggle for some of our patients to want to take care of their health. We've seen a spectrum of people in this respect, but there's just so many approaches you can take here. There's going to be a health literacy component to this. They have to understand what is going on with their health in order to take care of it. So you're going to have to address that. And then there's this philosophy of what we've called in our industry for a while of this motivational interviewing that we see done. And that is going to be really, really important. So if you have those resistant patients that don't want to do their exercises or don't want to stop eating high sodium foods, you're going to have to use some of those motivational interviewing techniques and to help them want to take care of their health. So a lot there, moving in a good direction, but obviously you can see here, Bud, that people are going to have to be thinking about their CAHPS and in a whole different way than in the past with these two questions.
Yeah, and I think it empowers the consumer again because they may have a different definition of what health means to them.
Exactly.
And so agencies are going to have to take the time, do the motivational interview approach to think about understanding what health means to patients instead of bringing their own thoughts, beliefs, and biases into the home, because that question is pretty broad. And so it gives patients and families an opportunity to answer it in a way that works for them.
Yeah, and involving the patient and the caregivers in their care plan. You might with a set of goals, but that's not the patient's goals. They're not going to take care of their health if you're not aligning the goals with what they're trying to accomplish, right? So this is the definition of patient-centered care and patient-centered healthcare. Some people are doing this really, really well right now, and they just need to continue that. Some people are going to have to rethink how they're approaching their care models.
Great point. Great point. Okay, Lindsey, so we've got the background, a little bit about why it's important, the CAHPS surveys are so important, and a little bit of detail around the changes and why it matters for agencies. Now let's get into what are the best practices, things that agencies can do to lift their scores, because surely this is going to be a major focus for all the agencies across the country as they try to drive better results.
Yeah, well, it's going to obviously start with looking at delivering those patient-centered models of care, which is a loaded thing because a lot of people say they're doing it and aren't doing it, so you have to see and measure that you're truly doing those things that are patient-centered. But the other thing I like to hit home with organizations is that a lot of times we say, oh, these CAHPS surveys, we send these surveys out and we don't have any control what happens, right? Like I can't control what happens with the survey and the outcomes. And that's not true. That's not true at all. You know, everything in home health has a different approach, a targeted approach. And I always say, if you know me, you know I love data. I dream about data at night. You got to start with your data. You've got to look at things. This isn't I have no control over what's going to happen once those surveys, once the surveys are sent out. There's a lot of research that has gone into best practices for CAHPS. And if you've ever heard me speak before, I've gone through all that research with you. But one of the key things is knowing your metrics and understanding it. What is your patient mix? What does that mix look like? How does that mix correlate to other organizations' patient mix? How does that mix then correlate to measures like hospitalizations? And then, then we get to, then how do hospitalizations correlate to CAHPS? This is what we call in logic it could be a slippery slope, but it's actually very related. If you sit in here thinking, that I have to look at CAHPS and then I have to look at hospitalizations and then I have to look at OASIS, you're not thinking about it right.
Right.
Look at your data and look at it all together, because the truth is what we see with the data and we can see with agencies' patient mix. I know I use a platform called Health Pivots, is that you can take a look at your patient mix, you can correlate that to your risk for hospitalizations, and then you can reduce hospitalizations through targeted approaches, and that's going to improve your CAHPS strategies. There's been research in this, but what the data shows us is that if you can reduce those potentially preventable hospitalizations, you're going to increase your willingness to recommend, and your rating are a 9 or a 10. And if you improve your discharge community, you're going to improve your willingness to recommend. And we sit here thinking, oh, why didn't I think of that? Because it's not rocket science, right? Like,
right.
You're a patient and you're going in and out of the hospital. Are you going to be happy? No, you're going to think, what's going on? Why am I still sick? Why do I still have to go to the hospital? Sometimes these things are in our control, but those preventable hospitalizations are. And so that's where you need to hyper focus on your data. And then downstream, you're going to see some improvements in your CAHPS scores. But know your data. That's what I have to say to organizations. Just this isn't a guess at all. It's a numbers game for a lot of people. And if you know your data, you can work with that to then improve all of your scores across the board.
Right. Great points. Yeah, you got to start with got to know where you are if you're going to try to figure out how to improve, for sure.
Yeah, absolutely. And then just another thing quickly is, we have struggles, because if you have a hospital that is discharging a lot of hospice patients to your organization, your home health organization, you're not going to get improvements. We know that. Why would you get improvements, right? That patient is actively dying and you're trying to make them walk further or get them to dress their upper body when they're not able to do that. So your OASIS outcomes aren't going to improve, your CAHPS outcomes aren't going to improve, your hospitalizations aren't going to improve. Of course, we have patients that are resistant to hospice. So you can't always control this, and this number is never going to be 0. But I like to think that, with the motivational interviewing strategies, you can start to see some change in this. There's a wonderful group by the name of Ariadne Labs that has done some videos on having those serious illness conversations that a lot of times we don't want to have. We don't want to talk to somebody. We don't want to tell them, you're not going to make it to your Glacier Park vacation in December, right? So, I think we have to start thinking of healthcare as more of a continuum, and you're there to help the patient get to where they belong on that continuum in a patient-centered way to help the healthcare environment as a whole.
Yeah, and it goes back to the prior section where we were talking about that question where CMS is going to be asking, did the agency help you with your health?
Mm-hmm.
Well, back to that topic of how do you define your health? Do you want to see improvement in ambulation? Do you want to see improvement in functional independence? Do you want to return to activities outside the home? Or do you just want to be comfortable? Do you just
Exactly.
want to prepare because you're at a different phase in your health journey, and it falls to the agency to figure that out.
100%, 100%. And,
Yeah.
that's not always going to align with things like OASIS, right?
Right.
But I have this view that if you're doing what's best for every patient, the outcomes will come. And
That's right.
so you've just, got to do what's best for those patients.
That's exactly right. What are some other things that agencies can do to move these numbers in a positive direction?
Well, one of the biggest questions that people are asking me all the time is, what technologies can we
Yeah.
use? And I said this on our training yesterday. I think, we're still early in measuring the technologies, but I do have strong hope and think that these will help with organizations in a lot of areas, right? We're here to talk about gaps today, but they're going to help in
Yeah.
a lot of areas. You have to think that if one of the main questions that is an indicator of success is how prepared was that clinician before they entered your home, that technologies that help clinicians be prepared so when they're entering the home, they can quickly get access to all those notes through interoperability and the EMR's capacity are going to help, right? And then we had talked the other day about ambient listening. If you're, there's a lot of research, particularly in hospitals, that if the doctor sits at the same level as the patient and makes eye
Right.
contact, then they are going to have better CAP scores than doctors that stand and don't make eye contact. Well, what's our biggest barrier to making eye contact and sitting and listening? Well, it's that note taking, right?
Exactly.
So I'm very excited to be looking at this ambient listening. We've launched a new study, the National Healthcare Home Best Practices Study. It's we've collaborated with Dave Bojanic at the Missouri University for Science and Technology, and we will be taking a look at that. And then, of course, there's technologies that are brand new, like what you work with, Bud, with the CureBestie AI calling, which is fascinating to me because it's something that
Yeah.
don't typically see, right? It's a brand new, innovative technology that that is going to really, help the staffing shortages, particularly, but also help with a lot of these different challenges that organizations are facing.
Yeah, I think and just speaking of CareBestie, and again, I'm an advisor for CareBestie, but having an agent in a CareBestie instance, it's an agent named Michael, to regularly check in and ask patients how they're feeling, and an agent that actually comes across as not human, but comes across as listening, empathetic, gathering information that's vital, and then bringing that information back to the clinician. To your point, there's nothing worse to a family than when somebody walks in the home and says, "Why am I here? Tell me
Mhm.
what's happening with you. I don't know anything about your history."
Mm.
That it completely destroys confidence from the patient and from the family. And so for clinicians to walk in and say, "I know everything that's going on with you. I've got a full update here. I read what was happening recently." That's very exciting. And that agentic opportunity to have more touch points with patients and families, maybe not more in-person visits, but more regular touch points, is huge. And then an ambient scribing technology, so it's eyes up on the patient, not eyes down on a tablet or laptop. I think that's extraordinary. Two really innovative solutions that agencies are going to have to think about.
Yeah, 100%. It's the future of healthcare. We have to work efficiently while providing great care, while also dealing with a massive increase in the Medicare eligible population and a massive decrease in the people who graduate from nursing school. So any data person will tell you we've got to start looking at things that help us, technologies that can support us in managing and navigating that giant shift that's about to occur or is occurring, I should say.
Yeah.
It's full circle. Know your data, understand it, measure your data, monitor your progress, and implement all these technologies to help make sure you're sustaining those best practices.
That was exceptional. Thank you so much for taking the time to educate us. Thanks for the conversation. I always like to end these kind of conversations or webinars with a couple of key takeaways for people listening to the webinar. So what would be a couple of key takeaways that you think everybody should take with them?
Yeah, well, the first I like to say a lot is this is not a wait and see approach. We have to be more proactive in our industry. You've seen it, we have VBP and we say, okay, let's wait and see how the chips fall before we make any actions, right? You don't want to wait until October of 2027 to get your scores and then say, oh no, what do I do now? Because that's going to be a huge endeavor to try to improve those scores. This is the time to be proactive. I know I've said this so much, but look at your data, look at your scores now, look where you can improve, train your staff in the changes, change your processes if they aren't patient-centered, and go into April 1st. So the survey is for patients who start in April. So the first survey will be mailed in May. Go into that with the mentality that you're here to help improve that CAHPS result, that patient experience of care. We can't wait and see how this is going to fall before we start to make some of those improvements. And then, just reinforcing that that the mentality of, if you are doing the right thing and not siloing, okay, this is what we're going to do for CAHPS. We're going to focus on this question. And this is what we're going to do for hospitalizations. We're going to focus on this. Just take a holistic approach is what the data is showing us. The outcomes will trickle beyond those individual silos. So, the patient-centeredness is really important, but making sure that you're not isolating these individual CAHPS from hospitalizations, from OASIS, from everything else, and seeing it more as these are our improvement efforts across the board. And then use your data, and then start to look at these technologies to help you implement some of these processes.
Yeah, I think that's exactly right. We talk a lot about you have to be able to learn, unlearn, and relearn. And so I encourage people to take a fresh perspective, be open to new ideas, try things, look at the data, and then react to it. So, Lindsey, thank you so much for your time. That was outstanding. And thank you to everybody who is taking the time to watch the webinar.